My name's Lala. I'm one of the emergency medicine consultants at King's College Hospital and also co-chair for the QIP. So why are we running this QIP? So I've just got some data. Some of it's a couple of years out of date, but it is the most up-to-date data we have at the moment. So the NSPCC stated that between April 2023 and December 2023, they had a 21% increase in contacts from parents who were concerned about their child's mental and emotional health compared to the same time frame in 2022. NHS England did a follow-up of a 2017 survey looking at the mental health of children and young people, which showed that 1 in 5 children and young people aged 8 to 25 years had a probable mental health disorder. And it's important to note that when you look at preteen suicide, there's been an increase of 8.2% between 2008 and 2022 of completed suicides in 8 to 12-year-olds. .gov.uk showed that the annualized rate of self-harm incidents per 100 CYP in 3 months to April to June 2024 showed an increase of 61% compared to the same period in 2023. And in England, a quarter of 11 to 16-year-olds and nearly half of 17 to 19-year-olds reported that they've self-harmed or attempted suicide at some point in their lives. Since 2013, we know that suicide rates have risen amongst younger males aged 10 to 14 and among females across all ages. And the Office for National Statistics tells us that the highest rates of suicide are amongst households where they have an adult who is a degree level qualification. Next slide, please, Lucas. So there was a systematic review and a meta-synthesis done looking at the literature, looking at the experience of CYP going to emergency departments for mental health support in 2024. And there were 4 themes that were identified, which I'm sure we can all relate to and would speak to as well. So EDs have been noted to be unable to meet the mental health needs of young people. EDs exacerbate patient stress. Patients feel like they're a burden or undeserving of treatment. And there are ongoing consequences of poor emergency department experiences. RCEM ran a survey in 2022 that reported that mental health services for children and young people were poor or awful, with no improvement since 2018. And I suspect the picture is going to be same or worse again if we were to review that now. Next slide, please, Lucas. Thank you. So one of the things we've noted is that we're now admitting more young people onto acute medical wards for mental health concerns. And there was a cohort study looking at this for the decade from 2012 onwards. So this showed that there have been large increases in the number of admissions to medical wards for mental health concerns for children aged 5 to 18 years in England over this period. Findings suggest that admissions for mental health problems in females aged 11 to 15 years now make up nearly 1/3 of all admissions in this age group, which is largely driven by increases in admissions for eating disorders. It was noted that this may reflect changes in care models in England because brief paediatric admissions are better than longer psychiatric admissions, but it was also noted that children and young people are being admitted, who are admitted to a medical bed, are staying longer in the hospital, with a proportion of admissions lasting more than a week, nearly doubling since 2012. Next slide, please. So that really frames why we're doing the work that we're doing. I'm sure that everybody would agree that, this is an increasing burden on our departments and we're not able to look after them in the way that we would all like and deliver the care we want. So Kate, I'm going to hand over to my colleague Katie, who will explain what we'll be looking at. Thank you.
Good afternoon. My name is Katie Manning. I'm another A&E consultant and a member of the topic team. So we have 2 main QIP standards that we as a team have decided to look at. Standard 1 is that all 10 to 17-year-old patients presenting to the emergency department should have an emergency clinician-led psychosocial assessment completed within their time in the emergency department. And that psychosocial assessment could be whichever assessment that the local team chooses. So common ones would be a HEDS or a HEDS ED, but it doesn't have to be. It's whatever would work locally for you to do. Standard 2 is that all 10 to 17-year-olds referred for mental health care by the emergency department. So 2A, that those young people should be responded to face-to-face by mental health liaison services, which might be adult or CAMHS, depending on your department and the age groups seen by those teams, within 1 hour of referral. And standard 2B is that those young people should have a parallel assessment by both the emergency department and mental health teams for an onwards care plan to be produced ideally by 4 hours after arrival and or discharged within 4 hours of arrival to the emergency department. And it's just worth being very clear that not all patients who are eligible for standard 1 will therefore be eligible for standard 2. So there will be certainly more patients eligible for standard 1 than will then go through to the standard 2. Next slide, please, Lucas. So inclusion criteria, we'll be looking at all 10 to 17-year-olds presenting to the emergency department, presenting with a list which would include any mental ill health, of which, of course, there are many different types of presentations that you might be able to use, substance abuse, social and safeguarding concerns, psychological distress or crises, and self-harm, which could be either self-injury or self-poisoning. Exclusion would obviously be anybody who is less than 10 years old or older than 17 years old, somebody presenting with accidental self-harm or a therapeutic overdose. And really anybody who is unable to undergo a mental health examination or risk assessment in the ED due to their physical condition. So someone that's either too unwell or potentially intoxicated and too obtunded, in whom we can't get any clinical history in order to make a mental health assessment, or there's no potential collateral history, or there's no electronic patient record history, or they are potentially requiring resuscitation level care, or unfortunately somebody that will be brought in dead obviously wouldn't be eligible for the QIP as well. Next, please. So looking further at standard 1. So standard 1 is all adolescent patients presenting to the emergency department should have an emergency medicine clinician psychosocial assessment completed within the ED. One of the questions that you will see on the data entry platform, so question number 7, will say, in the clinical context, was there a reasonable psychosocial assessment led by an EM clinician recorded? Now, it's just worth saying about the reasonable psychosocial assessment. So that's going to be a judgment of the person and the team locally entering the data as to what you decide locally is a reasonable psychosocial assessment. We did have a look at the data and we couldn't find a specific, you must ask about 4 areas to say that this is definitely a yes. So we would ask you just to use your reasonable judgment. If you say, yes, there was a reasonable psychosocial assessment, then the standard will be met for standard 1. If you say no, then that would be a standard fail for standard 1. If you say yes, the form will then go on to give you a drop-down list of the various areas that might be encountered in that psychosocial assessment. So then you can have the opportunity to see which areas you are able to which you have covered for that particular patient that you're entering data for or not. Next, please. So exclusions for standard 2. So patients who you were entering and they did not wait or self-discharge from the department will not be eligible for entry under standard 2. Nor will any patients in whom have not been referred to mental health services. And if they are referred to mental health services, but the referral is not accepted, or there is no mental health input that's recorded, then those patients will not be eligible for analysis under section standard 2 also. So just looking at a timeline for standard 2A about meeting the standards. So you can see a timeline here between arrival and departure. Somewhere in the middle of the patient's journey, there will be a face-to-face assessment commenced by the mental health team. And ideally, we are looking for that patient who is referred to mental health services to have a face-to-face assessment commenced within 1 hour by the mental health team. Doesn't need to be completed necessarily, but just commenced. You can. One of my previous
Over to you, Lala. Or
for standard 2B, you'll meet the standard if after arrival and within 4 hours, you have the face-to-face assessment done by the mental health team, and there's a documented plan by the mental health team for ongoing management. Next slide, please. So coming back to the conditions to fail, if the answer to the question was a face-to-face assessment of the patient by the mental health team completed in ED, either at triage or if there was a full assessment carried out by the mental health team, if the answer to any of those is no, not recorded, or was a telephone triage only, then that's a failure to meet both standards 2A and 2B. For the next question regarding the management plan being recorded, if the date and time is not recorded, that's a failure to meet standard 2B. If there's no documented plan provided, or the assessment has been deferred to community services, then that again results in a failure to meet the standard.
Over to you, Katie.
Apologies. So important timestamps. So in collecting your data, there's going to be a lot of different timestamps that you will see on the data entry form. There's a lot of common ones that you would expect, including the patient's time of arrival, the triage time, the time they're seen by an EM clinician, and the time they leave the department. But particularly for standard 2, we have some very specific timestamps that we will be asking teams to collect. So we would want to know particularly the referral time to the mental health team. So whether that is by your triage nurse after you have done a triage and decided in the spirit of true parallel assessment that that patient can be referred on to the mental health team whilst they're awaiting an EM clinician review also. The time of the referral to the mental health team. Then we would be looking for a timestamp for the time of face-to-face assessment by the mental health team. And then additionally, once the mental health team have been and seen the patient face-to-face, we need a timestamp for the time that the mental health management plan was created. Now, teams may have local ways in which they are going to obtain that information. That might be obtained from the clinical notes or the computer system in the ED. It may be that teams might be encouraged to work with their mental health team colleagues to collaborate and to use both systems in order to try and get the most accurate times. So we would leave that up to your local team to decide the way that you would find that most feasible to get those timestamps, but we will be asking you to record those timestamps in order to be able to analyze the data correctly. Next slide.
Over to you, Lala.
So there's some standard questions we're going to be asking. So there's some organisational data we've got, and that's around, for example, do you have a dedicated CAMHS room? What your policies look like around search policy, for example, what your safeguarding policy is like. And then there's specific questions relating to crisis management. So do you have a violence and aggression policy? Do you have a restraint policy? What's your rapid tranquilization policy? And then there's specific clinical data we'll be asking you to input. So there's demographics for each patient. There's the presenter complaint and the specific journey data points. So when the journey started in ED and when they saw triage and then saw the EM clinician, for example. We've talked about the psychosocial assessment and the elements of that. And then, as Katie's alluded to, there'll be the timestamps for the EM clinician and the CAMHS mental health referrals and assessments. There are then the specific outcomes. So if they were discharged within 4 hours, and if they weren't discharged within 4 hours, then what was the reason for the delay? And that may be they were waiting further assessment, they may be needed to be have a mental health act assessment, they may be waiting for social care, etc. But they're set out quite clearly, I hope, in the QIP itself. Thank you, Lucas.
Okay, thank you, Lala and Katie. Just before we move on to questions, please, everyone, we're just going to go through a few questions we have already received from the audience prior to the webinar. And following those questions, we will then have an open Q&A session for everyone here in attendance, if that's all right. So moving on to the first question we have. Over to you, Katie.
Okay, so this question was around safeguarding concerns. So the question was, should safeguarding concerns be captured only when they've been raised prior to or during the ED attendance by the young person or an associated professional, or where the young person has explicitly disclosed the safeguarding concern, or is it expected that ED clinicians actively screen and probe for safeguarding issues in order to meet the criterion? So as a team, we think that to meet the QIP inclusion criteria, the identification of safeguarding concerns should be based on the presenting complaint. So it would either be a clear safeguarding concern on arrival raised by the young person or a professional, or clearly identified within the triage process, rather than a safeguarding concern that's flagged up only when you've done a HEDS assessment, as that will potentially be biased in terms of you would have to do a HEDS assessment in order to find out there's a safeguarding concern. But I mean, all patients, you know, we would like to see getting HEDS assessments overall. So it's absolutely important that those aspects of the patient's psychosocial history are fully explored, but, you know, within the context of the HEDS assessment. No, absolutely.
The next question was a specific question from somebody from a site which has an in-house mental health liaison team who do attend within 30 to 60 minutes of the referral, and therefore their ED clinicians don't routinely complete a psychosocial assessment. And the question was whether the mental health team assessment, if that includes a psychosocial assessment, would that qualify as meeting the standard? But as a team, the aim of the QIP is that we improve the psychosocial assessment, and it's ED-led. So we've said that actually to meet the standard, it has to be an EM clinician who's carrying out that psychosocial assessment. And it's important for patients to feel validated. Part of the question was, you know, in their particular trust, that means that the patient has to repeat their story, would have to repeat their story twice. But we very much felt as a team that, and we know in our experience that different things can be disclosed to different healthcare professionals. So we felt it was important to kind of maintain that stance, and that actually the more people that are asking the questions, the more helpful that will be to support the young person in their journey through the ED.
So I can see one of the questions in the chat actually will be answered by this particular one. So how will the organisational questionnaire be distributed and how often? So the site QIP leads, which are named on the registration form for those sites that are all fully paid up to take part, which in my particular trust, I think is people in our data and quality team are predominantly leading on that, will get an email with a link to the organisational questionnaire, and that should be coming very soon. If not already, Lucas, I think. So teams will get reminders throughout the year, and the requirement is just that there's one submission per year per site. So there is, you know, plenty of time to get going with the organisational questionnaire on that.
So the last question we had submitted prior to this webinar was a question about when sites can start to see their results. So we're hoping that sites will be able to see their local results on the QIP dashboard towards the end of this month, so March 2026. and they should also be able to see a comparison with national data. The first national reports are due to be published in the summer of 2027, and the local report shortly after.
Okay, thank you, Katie and Lala. So just for everyone here, a quick overview of the next steps. The first one, of course, is if you are not registered to take part yet, please do so by following the link. It's also available on our website. And of course, if you get in touch with us, we can supply that link as well. In regards to the data entry period, it will be from the beginning of February when we started the project up until the end of January 2027. Now, this is the data entry period, which is the period you are allowed to submit information. For the data inclusion period, we're looking for data belonging to patients attending your emergency department from the 1st of January 2026 to the 31st of December 2026. So the whole year. Please only include patients which presented to your department within those dates. When we get to January 2027, you can retrospectively do data entry for those specific patients. The organizational questionnaire follows the same data entry deadlines, so you will have until January next year, end of the month, to have your organizational data submitted. And as Lala mentioned, we will only need one submission from your hospital. If your trust has multiple hospitals, please bear in mind we're expecting individual submissions per hospital, not per trust. The local reports and national reports should be coming out in summer 2027, and we are aiming to have those released within 6 months of the data entry period closing. We will have later this year a study day for this QIP in specific, adolescent mental health, taking place on the 18th of September. And we'll also have a quality improvement fundamentals day on the 23rd of October. Some of you might have attended this same event already. We ran in March last year, and it covers all aspects of quality improvement, not limited to a single project. And upcoming as well, we'll have our survey for the 2027 Prioritizing Patients' Pain project. So this project will be starting in end of January next year, and we'll be opening registrations for it later this year around October. But we already have the information pack available, and we should be sending out to everyone interested in taking part sometime next week. So if you want to provide a feedback, we're very much looking forward to it. That's very important to ensure that these programs are of a good quality. So please do register to participate, and we'll be sending you the materials for your review. Now, moving on to our open Q&A session. Please, if you have any questions that have not been answered already, I would like to invite you to unmute yourself and ask that question. If you're not comfortable with speaking, you are more than welcome to put on the chat as well. But just bear in mind, because the meeting is being recorded, preference will be given to those that unmute themselves in terms of how we're going to address the questions, if that's okay with everyone. I see we have a hand up already. Ms. Pahudin.
Thanks, Lucas. No, I have put down in the chat as well, but I'll just put it across. I have two questions. Number one, I see this standard one is for all the adolescent patient, which means that the patient who might be for trivial injuries or illness, they also have to be included in the study to get the heads assessment. The question is, how are the trusts doing it? Because that will increase the time to triage if the triage nurses are doing it, or the clinician's time to review the patient, so how they are doing, especially in case of the injuries, when the most of the injuries patient are seen by the ENPs in most of the trust. So how are the ENPs doing that heads assessment, or the triage nurse doing heads assessment? Number one. Number two is regarding the turnaround time for the referral for the CAMHS. Is there any DGH which has off-site CAMHS services providing that turnaround time within an hour? And how are they able to achieve that? I would like to know. Thank you.
Will I take that one? So the question about standard one, I would say that, of course, we would, in the bigger picture, advocate that heads assessments are used for all adolescent all-comers to emergency departments. I appreciate that's a challenge for the shop floor. However, for the purposes of this QIP, we are only looking at including patients whom have presented with mental health issues, safeguarding issues, substance misuse, or self-harm, or which can be self-injury or self-poisoning behavior. So we are not asking you, in the circumstances of this particular QIP, to do a heads assessment for all adolescents presenting, just adolescents which meet those particular entry criteria. As to your second question, I would say that I think we know that the 1 hour target is a tough target to meet. And, from a pragmatic point of view, I think that there will be a lot of places where, especially where there's off-site CAMHS teams, that this is not going to be met initially. But the QIP is a 3-year QIP, hopefully. I think, really it's going to be about quality improvement. So what are you currently doing, and how can you work with your local teams to advocate for a better experience for these patients, and how can you improve that locally? So it may well be that you are not necessarily meeting your 1 hour target, but how can you improve that?
Thank you, Katie. If I could come to you, Lorraine.
Oh, hi. I just wanted to clarify the EM clinician. We have a system where if our triage nurse thinks they need a CAMHS referral at triage, they'll use the heads tool and then refer, or a meaningful assessment, and will refer directly to CAMHS at that point. They may not then see an EM clinician if there isn't a medical reason. Is that an adequate, is it acceptable for that to be counted as an EM clinician? Because that's what we would do.
I'm happy to answer that. I think that is perfectly acceptable. I think that I agree with you. I think the triage nurses do excellent psychosocial assessments.
Yeah.
And this is the point is it's an EM-led assessment rather than a mental health-led psychosocial assessment.
Brilliant. Okay.
So I think that meets the criterion.
Yeah, brilliant. Thank you very much. Thank you.
Thank you, Lala. Please, everyone, should you wish to ask any questions, feel free to raise your hand. I don't see any, so I'll just go through the chat here, if that's all right. So I have a question from Joe Stone regarding where is the organizational data collected? Joe, there should be an email going out, as Katie mentioned, to all the named leads on the registration form, which will include the link for you to complete that. And hopefully we'll be adding that link to the portal as well. Another question I have here from Shahira. When do we start data collection? So Shahira, the data collection for this project already started, and it will be going on until the end of January next year. I see another question from Joe Stone for question 12.2.1. If the patient is not referred, could there be not a no referral, not applicable option? Just for clarification here, Joe, if you indicate that there has been no referral, then under this question, if you answer no management plan because there has been no referral, it won't penalize you for any of the standards. Any patients that are not referred, they are not included on standard 2A or 2B. I have also a question from Magna. What is data inclusion periods? If referring to the data inclusion period for submitting data, Magna, this will be from beginning of February this year up until end of January next year. If it's inclusion for the study itself, it is limited to patients presenting to your department from the 1st of January this year up until the 31st of December this year. And I think I have your question here, Ms. Bahudin, which I believe was already answered. I have a question from Jamie Egleton here. They're asking, would the heads assessment need to be documented? I believe that would be the case. Katie and Lala, is that correct?
Yeah, I think for the purposes of this, we need to document the heads assessment. So whoever it is that is doing it, there needs to be documented in the notes in some form, whether that's a specific performer that the trust intends to use, or whether that's even just in the notes if you don't have a pro forma. But I do think that needs to be documented somewhere in order for when you say, yes, a reasonable assessment has been done, and then you get the next drop down to say whether you have explored or not explored all the various aspects of the heads assessment, for example, home, education, sexuality, suicide risk. So then we'll be asking whether they are explored or not explored as part of the data entry portal. So we will need to know which aspects have been covered and which haven't.
Thank you, Katie. Next one up, I have a question from Karen. Our senior ED nurses do nurse-led mental health assessments, see them and refer quicker, and are much better and more mental health trained than our SHOs. We consider them ED clinicians, and they get a good timely service at Wexham as a result.
Thanks, Lucas. That was just in response to asking if nurses were considered EM clinicians, and Lala's answered that already. My question was going to be if anyone's using the Heads app, and if so, if anyone's got any advice as to how we can introduce it into our trust, and if it was useful for them.
I can only speak from personal experience, and that we do use the Heads app locally, and I think it is a very valuable. However, I think for the purposes of this QIP, the Heads app isn't going to cut it, because unfortunately we don't get any feedback from the answers given by either the young person or the professional or the carer, whoever it is that's kind of filled out the Heads app. So unfortunately, whilst you know, for me, it's absolutely better than not doing anything at all and signposting a young person to resources, which if you've paid up locally might actually signpost the young person to local resources, depending on the issues that have been raised. I think, unfortunately, for the purposes of this QIP, just having the app is not going to be sufficient.
Thanks, Katie. We were just hoping that it was going to be smoothly streamlining into our EPIC system and answer all our hopes and dreams. One day, perhaps.
And we haven't been able to smoothly streamline it into EPIC either. Okay. So we've had to set up a separate,
such a shame.
Separate, for a pathway for it.
Thanks so much. It's useful. I'll stop idolizing it then. Thank you.
Thank you, Katie and Lala. I have a question here from Ibrahim. How many hospitals have CAMHS cover overnight? So I think that's a question for everyone in attendance. Dion, I see your hand up.
Hi, hi everybody. So I mean, it's a good question, and I just wanted to add on there, and you know, people can answer, and I can answer not and outs as well. But I want to sort of from the purpose. So I'm also part of the QIP team. So for the purposes of the QIP, two things that I think are relevant. One is that the college, and Lucas, you can give us maybe a timeline on this, is the college is in the process of setting up a sort of community of practice type forum on the NHS Futures platform, where that type of question is absolutely ideal. We're obviously not prescriptive in the QIP about what sort of changes you want to introduce, but that's a perfect example of saying, we've tried this, how have you done this? And that will be an opportunity for that to happen, and share best practice, because we all struggle. If there are specific questions related to the sort of, you know, the operational functionality of the QIP, then of course the college quality team via Lucas can sort of help if there are issues. But in terms of making suggestions of change and everything, there will be a forum for that. That's one thing I wanted to say. The other thing, Lucas, was maybe just could you clarify, because you said to, I think, Megna's question, the data entry, you said being from 1st of Jan this year to 2027. But can you just clarify, which is next year, but can you just clarify that this is a multi-year QIP, and that, you know, obviously, yeah, can you clarify that, the answer to that question of it being a multi-year QIP, what the data entry is? And then before you do that, I just want to say that the reason why this is a multi-year QIP is because it is difficult. And actually, you know what, we had a long chat about this, and we said, you know what, for something like this, which is really tricky area, we need to do quality improvement in the same way that we work on the shop floor, and that is together with your mental health trust team. So we had sort of lots of discussions about, oh, well, that's not in the gift of either ED to make a change to, you know, a response time of a different team. Fair enough, but you know, we work together, and we need to work together to improve the care of patients walking through the department. So it may well be that you go and say, you know, we need to have a very good relationship in terms of improving what we do, and because of because of the fact that it's maybe two organizations and it might be a little bit harder, it may take some time. And you know, related to the question about CAMHS services overnight, this I mean, we were hoping it's going to be sort of 3 years, but this may well be your, and you know, my beginning of a process of going to our ICB and saying, look how bad we are doing compared to the rest of the country. You need to get us some better CAMHS services. So we had a conversation with some of the college leads last week, and they reminded me of something important, which is we often go about, are we meeting standards? Are we not meeting standards? This isn't a sort of a punitive process of you're not good enough or not. This is a quality improvement process, and that's the sort of, you know, long-term aim. And to say, well, we don't have services overnight, recognizes that in year one, which brings me back to the question, Lucas, about giving us the sort of time frame over the course of the QIP. But it also, you may also not in year 2 or year 3 have your ICB saying, right, we've got more CAMHS standards, or maybe in the next whatever years, but you can start making changes, and this will give you the evidence to do so. And it's stronger because it will have all of the national data, how you compare, and we completely acknowledge that in the first year, probably a lot of places are going to go, no, completely fail standard 1 for 1 hour for a 10-year-old child because their CAMHS service doesn't cover that. It's aspirational, but it's important, and we need to do it with others, I think. And this is, these are not decisions that have been made without really considering it. And the last thing worth saying is we had a CAMHS consultant work with us on the QIP team. So this is also not done, in silo. Just this is what we as EM clinicians want to do. They agree that this is the sort of thing we need to aim for.
Thank you, Dion. Just for clarification regarding the 3-year periods, for year 1, the inclusion period, so you should be looking for patients presenting to your department within this period for year 1, that is from the 1st of January 2026 to the 31st of December 2026. Year 2, same thing. 1st of January 2027 up until the 31st of December 2027. And for the 3rd and final year of the project, that will be again from the 1st of January 2028 up until the 31st of December 2028. Now, these are the data inclusion periods, which are, you should be looking for patients which presented to your department within those periods. For data entry is slightly different. We go from February 2026 up until January 2027, the end of the month. And then the same thing happens again for year 2. We'll start in February 2027 up until 31st of January 2028. And then for the final year, we have February 2028 up until January 2029. Of course, there might be slight readjustments if there is a need to introduce an extension to the data entry periods. But at present, these are the dates for data entry and inclusion. Okay. So I think no more questions I can see in the chat here. If anyone would like to mute themselves to ask any other questions. All right, I don't see any movement, so I think we have exhausted all questions. Thank you everyone for taking the time to attend the webinar today, and of course, thank you for participating in the project. And if you are not participating yet, please do sign up. Take part in this project. Is a very special one because it's the first time this project is being done by RCEM, and we're very much looking forward to everyone participating. Your contribution individually are all brought together to create a very powerful and clear national picture. And that really comes from everyone taking part. So thank you for that. And of course, thank you for our presenters here today, Katie and Lala, for taking the time to help everyone and introduce the project. Okay, I'll finish here. If any questions, please do contact us by email. Our phone is available as well on the website. And we're looking forward to working with you all.